Good morning, everyone. I'm Dr. Tara Kiran. I'm a family doctor at St. Michael's Hospital and also the Vice Chair for Quality and Innovation at the Department of Family and Community Medicine at the University of Toronto. I'm delighted that we can continue to bring you these sessions together with the Ontario College of Family Physicians. And throughout this time, we've also had Dr. David Kaplan, Vice President at Ontario Health, as a co-host and partner on the sessions. And I'm delighted to turn it over to him today to introduce the session.
Thank you. So today we're moving on and talking about what's new with COVID-19 and monkeypox. Dr. Tara Kiran is our moderator as always. Dr. Kiran, as all of you know, is the Fidani Chair of Improvement and Innovation at the University of Toronto and the Department of Family and Community Medicine. We have two wonderful panelists this morning. Dr. Allison McGeer from Toronto and Dr. Darrell, also from Toronto. And a reminder that this community of practice is accredited for 1 credit per hour for group learning to a total of 32 credits from the OCFP. Next slide. I'm going to begin this morning with our land acknowledgement. I want to acknowledge, and we want to acknowledge, the lands on which we are hosting this meeting include the traditional territories of many nations. This land that I'm speaking to you today from myself is the sacred territory of the Mississaugas of the Credit, the Anishinaabeg, and the Haudenosaunee and the Huron-Wendat peoples. The OCFP and the DCFM and the DFCM recognize the many injustices experienced by the Indigenous peoples of what we now call Canada continue to affect their health and well-being. The OCFP and the DFCM respect that Indigenous people have rich cultural and traditional practices that have also been known to improve health outcomes. As a Canadian Jew, I know what it means to lose one's land and to be persecuted and to be a minority religion and culture. When we were thinking about my reflection today, it allowed me to reflect on the fact that the wounds of oppression and displacement do not end with the person who suffered the initial trauma. There are second and third generation reverberations and trauma on individual and collective levels. I recognize that many of you are attending virtually today are working on parcels of land that don't apply to this land acknowledgement. And I invite you to take some time after the meeting to learn about the history of the land you live and work on, and think of how it is connected to the important work that you do every day. And though my family has also suffered displacement and cultural displacement, I want to acknowledge the ways in which I, as many of us on today's call, as non-Indigenous people in Canada, have benefited from European colonization, which has hurt and oppressed First Nations peoples. We ask for their forgiveness. May we live in respect on this land and in peace and friendship with its people. Thank you, Tara.
Thank you, David, for that. Next slide. So as usual, we'll be building on our past sessions. Our last session was 4 weeks ago. We took a bit of a break, and you can watch the recording there. We had Dr. Gerald Evans give, for example, a monkeypox overview, as well as doing some work, some updates on COVID, and that'll be built on today's session. And as usual, today's session recording will also be available at the end of the day here. Next slide. Now I'm delighted to welcome our panelists. Next slide. I'm going to turn it over to them one by one to introduce themselves. Allison?
Unmute myself. Okay, so a new record for not unmuting myself. Apologies. Allison McGeer. I'm adult infectious diseases at Sinai Health System in Toronto. Good morning, everyone. And you see my conflicts on the slide. Thanks, Tara.
Darrell?
Good morning, everyone. My name is Darrell. I'm an infectious diseases physician and clinician scientist at St. Mike's, and I've received, my institution's received research support from AbbVie, Gilead, ViiV, and GlaxoSmithKline. Thanks.
David?
I'm Dr. David Kaplan. I'm a Vice President of Quality at Ontario Health, and I receive salary support from Ontario Health for that role, and I also receive an honoraria from the OCFP for these sessions.
I'm Tara Kiran, and I'm fortunate to have some research funding and salary support. Only a couple from for-profit companies, but they don't pose their conflict for today. Next slide. So today we're going to build on previous conversations and just hear about the latest on COVID, where we are with case counts, new variants. We'll hear a little bit about the children's vaccine, which I know people are really interested in knowing more about, as well as more data and evidence around boosters and Paxlovid, and of course, answer your questions. And then we're going to turn it over to Dr. Darrell Tan for a monkeypox update. Lots has changed since the last time we spoke about this, so please stay tuned for that. And please do continue to put your questions in the Q&A. Next slide. That's a big part of what makes this work, as you know, and so we'll be doing our best to answer all the ones that get the most thumbs up. So instead of putting in a new question, please do instead vote up someone else who has a similar question, and I'll be prioritizing those with the most thumbs up to answer live. And you can use the chat, of course, as you already are, for networking and shout outs and providing people with resources and information of your own. Next slide. So without further ado, I'm going to turn it over to Dr. Allison McGeer. Next slide.
Hi, everybody. Okay, so let's talk quickly about a few new things about COVID and vaccines. So the first slightly annoying thing, if like me, you're obsessively watching what's happening to COVID in wastewater, is that you can see that the COVID signal in wastewater is bumping up, sadly more in Toronto than other parts of the province. And that's probably one of two things, or most likely some combination. The first is, remember, we did walk back a bunch of the mask mandates. You can see all of us relaxing, fewer people are wearing masks. It's going to increase transmission a little bit. And BA.4/5 is coming. I'll just show you that in a moment. I think the general prediction is that this is not going to be big and it's not going anywhere in a hurry. We're seeing BA.4/5 take over gradually everywhere. It does cause a bit of a bump, but it hasn't been bad anywhere else. So we're just expecting a little bump up and come down again. But it does mean, you know, just watching and being a little bit careful about how fast we're walking back precautions for the rest of the summer. So take a look at what's happening to BA.4/5. Let's go to the next slide. So this is PHO's beautiful colored picture of what's happening to variants over time. It runs back a year. So you can see last year in the dark blue on the left-hand side, Alpha coming up, and then the pink is all Delta. I don't think of Delta as pink, but whatever. And then you see in the light blue, you can see Omicron coming up, and then below it in purple and green and orange, the various subtypes of Omicron. And right on the top left, at the beginning, so this is the last 2 weeks of May, you can see BA.4 in the light orange and BA.5 in that fuchsia color appearing on the slide. Looks like nothing, but actually this ends the week of May the 29th, okay? On the week of May the 29th, on this, that BA.5 is about 5%, and then click down one. And then you can see on this graph what's happening at UHN Sinai, because we don't yet have an update for the whole province. And what's happening at UHN Sinai is we had like one isolate each, first isolates, in the first 2 weeks of May. And as of last week, we're about 35%. So this is like Omicron taking, this is Omicron taking over Omicron again. And you can see that the numbers are going up really quickly. So it's kind of good news and bad news, okay? Good news is that it's not going up faster than it is, okay? It's only going up a little bit. Bad news is we are going to see BA.4/5 taking over as it goes. And that does mean, you know, as we know, that there are going to be some people who do get reinfections, right? Because you can have had a BA.1 or BA.2 infection January, February, March, April, and get a BA.4/5 infection. Not usually serious disease. 3 doses of vaccine are still going to keep younger people out of the hospital, but you can get reinfected. Next slide. Okay. Vaccines for kids under 5, as you know, have just been authorized in the United States, started vaccinating earlier this week. It's going to be a really interesting question about how people decide if Health Canada authorizes them both. And we're expecting that Health Canada decisions will happen in July, so that by August, vaccines for younger kids will likely be available. Pfizer chose to go with a much lower dose. So they're at 1/10 of the dose, 3 micrograms instead of 30. But the price for that was the first 2 doses didn't work. So you have to have 3 doses of the Pfizer in order for it to work. So that's 0, 21 days, and then 8 weeks later. So it's a total of 11 weeks to get your 3rd doses in. The estimate of effectiveness on 3rd dose in Pfizer is 80%, but the confidence limits are huge. So the FDA actually said that they didn't put a number on it. They said it's effective, but we're not going out and telling you how effective it is. The good news about Pfizer is that it's got lower reactogenicity than Moderna. So it's a trade-off, 3 needles, but lesser reaction to each needle. Moderna, in contrast, went with 25 micrograms, so that's half their adult dose, 2 doses at 0 and 4 weeks. Their efficacy, you look at that efficacy initially and you think that looks low, but in fact, remember this is Omicron and nobody is perfect against Omicron, so it's not probably different at all, but you do get an excess of kids with fever and a little bit of an excess of lymphadenopathy and nausea and vomiting and irritability that is greater than with Pfizer. So it is, I think, going to be difficult for people to choose for their kids when the vaccines come out. And I hear this conversation is going to come up again in subsequent discussions. Next slide. Just a quick reminder, these are data out yesterday in JAMA Internal Medicine on 4 versus 3 doses of Pfizer in residents of long-term care, which looks a lot like the previous data in people over 60, okay, which is that vaccine efficacy against any case of COVID for 4th dose compared to 3rd dose is about 36%, not huge, but not insignificant, but against severe disease, it's up about 75, or it gets progressively higher as you get to more severe disease. So this is why we're recommending 4th doses for people over 60 and 4th doses for residents of long-term care, where there's still a significant, not nearly as great as it used to be, but still a significant risk of severe disease that we want to prevent. It also tells you why we're not recommending 4th doses for people under 60, because if you're under 60, 3 doses gives you really good protection still against severe disease. So nothing much changed in our assessment of vaccine efficacy. Quick note about new vaccines against variants. Moderna announced again yesterday, I think, that their new vaccine that they're proposing for the fall, which is half Wuhan, half one of the Omicron constructs, also works against BA.4/5, which is nice, although it's still only a press release. So we know that Moderna is planning to have that variant vaccine available in the fall. Timelines are really tight though, right? We're already almost July and it's got to be authorized and it's got to be produced. Pfizer is also working on a bunch of different variant vaccines. They haven't said anything about how well they're working, but almost certainly something is coming with their vaccine as well. So we're all still hoping for variant vaccines in October for boosters. Next slide. And then lastly, just a quick note, there was a bunch of press this week about Paxlovid not working as well in standard risk patients. Again, this is science by press release again, but these are the numbers in the Pfizer press release, and I put them up for 2 reasons. The first is that we don't know yet what did not meet endpoint on alleviation of symptoms means, but it is true that we don't have data that says when you're treating somebody that you reduce the risk of transmission of other people, or you make symptoms go away faster, or virus go away faster. So you need to be a little careful about that. And then the second thing is that when you look at these data, you still see an effect of Paxlovid on reducing the risk of hospitalization and death. It's maybe a little bit lower than it was in the initial trial, but it's still there. So it just highlights the fact that this drug does work to reduce serious complications in people at risk. It's just still really hard to choose who's at significant enough risk to get this drug. So I don't think it should change anything anybody's doing. All of us are just trying our best to use the drug responsibly and sensibly, and we're just going to have to keep doing that. I think that's the end of my slides.
Thanks so much, Allison. I think you've answered lots of questions that have been coming up. Maybe we'll just end slides, Olivia, and I'm going to go right to the Q&A to get some of the top asked questions. So Allison, one of the Salwa Azar says, recently lots of my patients have had viral illness with loss of sense of taste and smell and negative multiple rats. Does BA4 and 5 evade detection by current rats?
No, so I think it's complicated. There's a bunch of things going on. First of all, the more vaccinated you are, the greater the likelihood that you're going to get through an episode with negative rats. It happens sometimes, but it's also true that we kind of ignored the loss of sense of taste and smell that you get with other viruses before COVID. It's been really prominent with COVID, but it actually happens with other viruses as well. So I think it's this really complex mix. Very definitely, as we've reduced the masking and gotten back into contact, other viruses have come back, right? There's a bunch of hand, foot, and mouth disease in daycares. There's been some flu and some RSV around. So we are seeing other viruses. You do get some loss of taste and smell. We are seeing a reduction in severity in COVID in people who are very well vaccinated. That means sometimes rats are negative. So it's just a mess, fundamentally.
Thanks for that honest answer. I'm going to ask a question that Jennifer Tran asked, which was, there was a paper recently studying the effects of repeat COVID infections and cumulative severity. Can you please comment? I know David wrote something in answer to that as well, but Allison, and I wonder if you had anything to add, and David, if you wanted to pipe in as well.
I don't think so. David, go for it.
Yeah, I was just, so it's I did answer it in text, but it is a preprint non-peer-reviewed article coming out of the Veterans Administration. 10% of the patients, because of the nature of the population, were women. So it's not a representative sample, obviously, but it did show a signal that in unvaccinated and in non-boosted individuals, there was a dose response curve with the severity of symptom or long-term severity of symptoms with multiple injuries to COVID, meaning, the more times you had COVID and you were unvaccinated, the more severe your persistent symptoms were. So I think it's a really good study to help convince people who are not yet boosted to get boosted if it shows that signal. And obviously, I think we should all wait till it's peer reviewed, but it's a large study. It was like 35,000 people in the study, I think, but 90% men.
I think also important to recognize that risks in that population of reinfection are much higher than they are in Canada. And even in that population, it's a really small number of people who've had recurrent infections. So I don't think people should be losing any sleep over what they're doing to protect themselves. But it's not impossible that repeated infections might have some cumulative effect. It had, there is an element of, we'll see if anybody else finds it. The group who are doing that analysis at the VA are not people with a lot of experience doing that kind of analysis in large databases. I admit to being a little bit anxious about their findings. So I really want to see peer review on that before I'm sure it's true.
So Samar Samaha says, would healthy kids aged 12 to 19 with 2 doses of COVID vaccine followed by mild COVID illness benefit from a 3rd dose?
Yes. Will they benefit a huge amount? Maybe not, but will they benefit? Yeah. I think the messaging here is we all want to be up to date with vaccines, and up to date if you're over 12 is 3 doses.
Okay. And so then, Allison, there are a couple of questions just building on the remarks you made about the kids vaccine, the vaccine for kids under 5. So Alan Grill says, what type of uptake should we expect from kids under 5 to get the COVID vaccine? Given hospitalization rates in this age group has been low, do we think parents will be enthusiastic? And there's another question here on a similar kind of Sandy Khan says, can you comment on the risks of severe illness, hospitalization, and death in the under 5 population? Do the risks of COVID really warrant recommending the pediatric vaccine given the low VE?
So I think two things on this. The number that struck me was that in the discussions at the FDA panel this week, somebody pointed out that 202 children aged 6 months to 5 years have died in the United States from COVID. And when I first heard that number, I thought, oh, that's practically nothing. It does, however, make COVID the 5th leading cause of death in kids in that age group for the last 2 years. So the reason that the FDA panel voted yes, and the reason that NACI is likely to recommend it is that you're right, the benefits, think chickenpox vaccine, okay? Most kids who got chickenpox didn't get seriously ill with it. But there's still very good evidence that getting chickenpox vaccine is a benefit to kids, even if you discount the later benefit of protection against shingles later in life, right? So just the upfront is still worth it. So if we get a recommendation from NACI, it's because pediatricians and people who think carefully about this have looked at the risks and benefits and are absolutely convinced that there are benefits and kids that age should get vaccinated. What the uptake will be, I think is really hard to judge. And I think may depend a lot on what happens to COVID activity in the fall, right? There's going to be a group, I would put it at, you probably have more experience than me, maybe 25 or 30% of parents who are going to be keen to get their kids vaccinated are going to be out right away. And then the rest of it will hinge on, whether we see new variants, what we know about vaccine efficacy against new variants, how much activity there is in the fall.
Thanks, Allison. So I think Jenny Clement wrote in the chat, and to put it in perspective, we treat all women who test positive for GBS in pregnancy with IV antibiotics to prevent 1 in 4,000 infant deaths. And Alan Grill said, I've also been told by pediatric colleagues that hospitalizations from age 6 months to 2 years increased the most during the Omicron wave. So yeah, there are good reasons to try and, to think about vaccination. Of course, we need to wait to see what for the Health Canada approval. So I'm going to ask a question from Diane Hawthorne. Healthy 60-plus-year-olds with 3 doses of COVID and Omicron in February, March, April. Should they be boosted now or wait for the fall for the possible new vaccine?
So to me, the answer is yes to both, okay? I don't see why we would not want to protect people over the summer. And I think, I know that most vaccine courses are 2 doses or 3 doses, and 5 sounds weird. But this is a pandemic, okay? It's happening, well, we thought it was happening once in our lifetime, although now it's monkeypox, who knows, right? This is not business as usual. And I have absolutely no qualms about people getting their 4th dose now so that they can have a good summer and not worry about messing up their holidays and whatever travel plans they have. And they get their 5th dose with the variant vaccine in the fall. There's no reason to think that getting an extra dose of vaccine is going to do you any harm other than, the pain in your arm from the needle and the reactogenicity. So, I think the answer is yes, they should have their vaccine now, and yes, they should have a booster in the fall.
Great. So then the next question is for you, David. Jennifer Atwood has said, is there any indication that the need for documentation in COVAX will be discontinued? As we prepare for the fall and likely another COVID booster, the vaccine seems to be becoming more routine. I don't see the benefit need for COVAX at this point. It's been a major barrier for the delivery of the vaccine in primary care in our area.
Yeah, so I think I haven't heard signals that COVAX is going anywhere. I think there's sort of 2 things that are going on. The first is that I think we had hoped, especially in primary care, that we were going to be able to go to a single, that Pfizer or Moderna was going to go to a single dose vial, because that often is even a bigger barrier, is just lining up 10 or 14 people who need to be vaccinated on the same day, especially in a small family medicine office. And it sounds like that even though they're able to do it, they're not going to do it because they're still focused on getting a lot of vaccine out the door, especially across the world, was the last that we had heard from the ministry. I think where the ministry is going with this, and again, it's all conjecture, but is hopefully documentation in our EMR with a data out strategy into COVAX, and not just for COVID vaccine, but the idea would be that would be the way to get actually a registry of vaccination for childhood vaccines and other things as well. So I think the idea of having a provincial repository for vaccines is not new. I think it got expedited. But totally hear you on, having used COVAX a lot on the workflow issues, though I understand, I haven't seen them yet, but I do, many people on the call probably who are still using it, if you're working in clinics, have seen some changes to the workflow in COVAX to make it a little easier, including what I think was a big issue, which was the decoupling of giving a vaccine to a supply. And that was a real big issue that people ran into in their offices if the supply wasn't updated properly. So I wish I had slightly easier news, but I think it's still growing pains to get it to where it really needs to be, which is really documenting in our EMR and then that sort of being pushed up into COVAX.
And this is Allison doing a beg for some degree of forgiveness for this and for us working with the province to get this. One of our problems in Ontario is we haven't been able to make the best decisions about vaccine rollouts and efficiency of vaccine programs because we don't have any data on evaluation. And we have saved lives in Ontario because we had good data coming from ICES on vaccine efficacy. So I hear the issues with Covaxon. I've used it. It needs a lot of work, but there is an enormous benefit to the people of Ontario to having vaccine data available in ICES so that we can make better decisions about vaccination programs. So I'm really hoping that we can continue to work on this to get something that works for primary care practitioners, but also allows us to get data. It's not just a pain in the neck. It's a pain in the neck with benefits.
Thank you, Allison. I wonder, Olivia, if we can go to slide 35. And as we do that, I'm just going to read Jenny Clement's question. So Jenny just says, is the, I think she said CFPC, but I think she meant OCFP doing anything to fight back against the ridiculous statement from the CPSO saying that we must see patients even if they refuse to wear a mask. I am less concerned about me or my staff getting really sick, but one infected person could take out our whole office, which services over 10,000 patients. So, I think obviously we know that the provincial mask mandate has been lifted. It is still required in certain settings, but organizations have discretion to mandate masking for both staff and patients. And OCFP does recommend continued masking in community practices, given that we see numerous elderly and immunocompromised patients. Next slide. OCFP and the OMA have a number of resources to support masking and communication of masking policies to your patients. But I hear you, Jenny, that there will be patients who refuse to put on a mask. And I don't unfortunately have any OCFP colleagues on the call today, but we will ask them to comment on this and get back to you. But David, I don't know if you have any comments on this.
No, just that I can absolutely sympathize. I was saying to Tara and I were going back and forth in the chat privately, and I was saying this happened to me yesterday, and I had to see somebody who was unmasked. It was, I actually don't know if he was masked in our waiting room or not, because by the time I saw him, he was in the exam room. But, we have all the signs up in the world, and, but at the end of the day, it's really hard to turn somebody away who's already shown up in the office. I think that if we've had people call the office and ask about it, because we sent out an email to our patients reminding them that we're asking them to keep their masks on, and that's easier to be able to try to figure out if you can use a different modality for the visit. But I think it is very difficult if somebody's presenting for care to turn them away. it is not an easy predicament that we've been put in as family doctors and nurse practitioners.
Yeah, and thank you for people who
Oh,
are
and Jenny, I like that, seeing them outside, like in the parking lot or something. Yeah.
Yeah, lots of great stuff in the chat here. So Alan Grill says our office sees patients who refuse. We put them directly in a room, or they wait in the car until a room is available. And he's saying that the transmission to staff is low as we wear PPE. And of course, I'm sure your staff are also vaccinated.
Yeah.
And Alan makes the good point that ERs do not refuse to care for those without masks. I think Andrea Flip sees something similar. They try to put the people without a mask at the end of the day if there's warning, and put them in an exam room right away. And then I think you mentioned, David, I'm not as fast as you at catching up on the chat, but people are seeing them outside. All right.
And one other point, and she didn't post it to everybody, but one of my office mates posted to all the hosts and the panelists that we actually did have a mom come in with her sick child, and the staff only screened the mom. And of course, the toddler wasn't wearing a mask, but the toddler was the one that actually had respiratory symptoms. So just a reminder to your staff to ask about everybody who's coming in, not just necessarily the person who's coming to the front desk.
Thanks, David.
Yeah.
All right, so I'm going to just end slides, and I'm going to go to a few more questions before we go to Darrell. So the next question is from Jenny Clement. And Jenny says, can you please comment on the variety of recommendations about isolation for primary care? I thought it was 5 days and 24 hours of no symptoms, but the MOH website says 10 days unless you have a negative rat. Seems silly that I can go grocery shopping without a mask after 5 days, but can't see patients with an N95 and a face shield. I will say I still think that there is a recommendation to wear masks in indoor settings, even regardless of your profession, day 6 to 10, if the isolation is only 0 to 5. So just want to correct that. And I don't know, Allison or David, if you have any further thoughts on that question.
Yeah, I think the challenge here is that we want to interfere with life in general as little as possible, and very clearly how infectious you are is greatest just before and as you're coming down with illness. On day 5 to 10, you're significantly less likely to transmit than on day 0 to 5, but there is still some risk. So it's trying to walk that balance of when it's okay because the risk is low enough and when it's not. And a piece of that depends on who you're seeing. You know, if I'm doing inpatient consults with transplant patients, that's a day 10, okay? You know, if I'm seeing undergraduate students at the university, that's a day 5 with a mask, right? So it's one of those difficult decisions about how to balance you need to be providing care to people, you don't want to be canceling people, versus you also don't want to be putting them at risk. And there's no easy solution to doing that. You have to think carefully about what's going on and who you're seeing, and then make the best decision you can in each circumstance.
Yeah. Go ahead, David.
No, I was going to say, with Allison, I think there is a good element of clinical judgment there and risk assessment to your patients. And Allison makes it a really good distinction between, where you're working and what patient population you're serving. And it was no different. We had a lot of discussion provincially early on in the pandemic about sending people who were positive to work, like in work isolation, because we just didn't have, we didn't have people to see patients. And so we can't have, masses of healthcare professionals off, seeing otherwise pretty low risk patients for 10 or 14 days. So I think there is an element of, just clinical, being prudent, but also, using your best clinical judgment.
Yeah, so I think, and I think the RAT as, just using the RAT to see when you end up testing negative does seem to be a good way to judge contagiousness as you finish, as you come out of COVID. And I see that's what many of us are doing.
I think it's also a bit frustrating though, because you have to recognize that if you do start doing it, you can test. So two things, you can test positive out to day 8 and 9, and you just have to have the patience of Job. But the second thing I found with some of my patients is that they, then they test positive on day 10 and they think they have to stay in isolation after day 10 because they're still testing positive. And so it's really hard to persuade people that once you get to day 10, it doesn't matter what your test is, you're okay, right? So the judgment based on rats is just day 6 to 9, okay? You test positive on day 10, it doesn't matter anymore. Now, that sounds perverse, but it's nonetheless true. So just don't get trapped in the, if you test positive 8 to day 12, you're still a risk to other people and you have to worry about it. Not true.
Thank you, Allison. I think that actually clarified things for a lot of people, especially Alan Grill, who said he's isolated for 12 days because his rat kept testing positive. So he isolated for 2 more days than was needed, it sounds like. And Terry Weinberg asked, is that 10-day rule also true in long-term care setting? I assume it's like after 10 days, you're not contagious. That's what you're saying, Allison. And that's true. That actually answers another question from Cleo Mavropoulos, who says, is 10 days enough if a patient's had COVID to avoid seeing an immunosuppressed family member?
Yeah, so the only exception to taking people out of isolation on day 10 is in patients who are significantly immunocompromised, right? There are some people, post-transplant, on rituximab, who can have, persistent shedding of infectious virus for a long time. And those people you still need to worry about. But for all the rest of us, once you get to day 10, it's fine. I know it feels, there's nothing wrong with the Alan Grill approach, which is a couple of extra days just to feel safer. Okay, it's okay. But it's not necessary. I think, what happens in long-term care is people tend to get infected in outbreaks and then everybody's in precautions, and we don't stop the precautions for one person just because they're on day 10 after illness. So I think people do end up in precautions for longer in long-term care, but it's still the same principle. Once you get to day 10, as long as you're getting better, you're okay.
Great. So I'm going to take one last question and then we're going to go to Darrell. So Michelle Morty asked, Don Bodish was on the radio this morning saying that being within 3 months of a dose reduces your duration of non-severe symptomatic illness. That's a couple of days versus several days of being sick. Is there compelling evidence on this when most studies don't assess duration of non-severe illness?
I have not seen compelling evidence on this, but that does not mean that Dawn does not know more than I do. It hasn't seen more than I have. So I think she may be correct. I just haven't seen data yet.
Thanks, Allison. So I'm going to we'll get back to COVID questions at the end of our session, near the end of the session. But I want to make sure that we have sufficient time to talk about monkeypox, because there have been a number of changes in new knowledge and progression of epidemiology since we last spoke 4 weeks ago. And I'm delighted to turn it over to you, Darrell, to walk us through it.
Great, thanks so much, Tara. Thanks everyone for joining today, and thanks for the opportunity to speak. I also want to put a shout out, thank you so much, David, for the land acknowledgement, which I think is particularly important with respect to a new emerging infection. This particular virus is closely related to smallpox, and we know that the history of smallpox with indigenous populations on this continent is shameful. On the next slide, you'll see a couple of images that I wanted to present right up front to address a question that keeps on coming up, which is the issue of what's going on with respect to the epidemiology of this virus globally right now, and what are we allowed to say about it? What should we say about it? What are the risks and benefits? And specifically what I'm talking about is the fact that unequivocally over 99% of the reported cases reported by the WHO since the onset of this outbreak have been in men who self-identify as gay, bisexual, or another man who has sex with men. And ironically, since the beginning of the outbreak, certainly in Canada, there has been this kind of uncertainty on the part of many actors, I would say in the media, maybe some other authorities, about whether they should or could or are allowed to, say gay in quotation marks. And there's been concern, of course, you can see on the left here, about the risk that doing so could inadvertently stigmatize communities, 2S LGBTQ plus communities in particular, of course, and that there's a sordid history of that, and people are quite rightly and appropriately worried about that. I would say, however, that the opposite is also true, right? So the fear of this has led people to be silent about it, to not talk about it, quite intentionally at sometimes, and it's conspicuously absent. And I just want to remind us all that that silence can also do harm. The epidemiology is unequivocal, I think, at this point about what we are seeing so far. And acknowledging that is important to get the word out to folks who are at greatest risk. This is a public health and clinical issue that we need to get the information to the right individuals. So I think it's important to do that. And in fact, if one is concerned about, saying the wrong thing or stigmatizing people inadvertently, what's the solution? The solution is to engage the affected population. It's not difficult, and it's been happening, I think, very successfully in the Canadian response so far. And I really think that that's the key. On the right-hand side of this slide, you see some publicity material that was put out by one of our prominent NGOs in the province, the Gay Men's Sexual Health Alliance, GMSH. You can see the date on this information was May 20th, pretty much the days that the first cases were confirmed in Montreal. And we have a very rich civil society sector that's working on this issue that has been very vocal. So link with them. That is the way forward, I think. On the next slide, I wanted to open with the messages that I'll close with, which are a few key messages. Number one is how to suspect monkeypox as a primary care provider. And I'll focus a lot of the time on just some images to help with what I think at this point really is a lot of pattern recognition. So the key kind of sets of symptoms would include flu-like symptoms, so fever, chills, the like, skin lesions, which I'll show you how to recognize, plus minus lymphadenopathy, tender lymphadenopathy. And of course, especially in this population. It's not to say that other people cannot have this infection, reasonable to think about it, but really that is where it's concentrating at this moment. If you suspect it, then of course you need to be able to diagnose it. So I'll show you a little bit about that. The key diagnostic test is a PCR. But there are some details around specimen collection I'll quickly talk to you about. Of course, there are some considerations around infection prevention and control. And then there are some really kind of irksome logistical considerations right now around one's ability to safely transport specimens from your setting. So we'll talk about that in a minute. And then finally, a key message, I think, for primary care right now is, vaccine is available. We do have a limited supply. I put here that it's, through Toronto Public Health, because that has really been where the focus effort has been thus far, or your local public health unit. And it's right now for gay, bi, and other men of sex with men who meet risk criteria, which I'll show you, as well as close contacts of confirmed or probable cases. So let's move on. I wanted to start briefly with a slide that summarizes the traditional teaching on what we have known about the natural history of monkeypox infection based on experience in endemic areas. So historically, what we said was that there's an incubation period, 5 to 21 days, usually 1 to 2 weeks, but can be out to 5 to 21 days, followed by a febrile stage. So this is when people feel sick. They may also have an enanthem, so oral lesions, and they may also have this classic tender swollen lymphadenopathy. They are thought to be somewhat infectious at this point to other individuals prior to moving into the classic rip-roaring, rash stage that is more prolonged in duration, 2 to 4 weeks. And the skin lesions kind of progress through these various stages, from a macule to a papule to a vesicle to a pustule, finally in the recovery stage to like an ulcer that crusts or scabs over. Okay, so that evolution is shown on the next slide. And it's pretty familiar to us, I think, in clinical medicine. This is how most kind of vesicular viral illnesses manifest: HSV, VZV. The patient thinks of it as a dot to a bump to a blister or a zit, and then a scab, right? And we know it as macule, papule, vesicle, pustule, crust. You can see the images here. And there's a couple of characteristics I really wanted to highlight on this slide. When you look closely at the papules, vesicles, and pustules, especially the vesicles and pustules, you'll see, and I think you can appreciate quite nicely on these images, that there is a characteristic central umbilication to the lesions. It's kind of got a pit in the middle of it. And sometimes that central pit can become darker in color, kind of have a violaceous or even a blackish hue, and patients often describe it to us in that way. Another characteristic of these vesicles and pustules is that they kind of look juicier than they are. They look like they're really fluid filled and teeming with fluid, but when you actually examine it with your gloved hand, of course, they're quite firm to the touch. They're very well circumscribed and discreet, but they tend to be surprisingly firm, more so than you would expect for their appearance, more so than you would typically see with vis-a-vis or HSV. And that's something that I think many of us have observed. There's also a little bit less fluid inside them when you try to collect a sample. On the right-hand side of the slide, you can see a schematic illustrating the classic description of how the rash evolves. Typically starts on the face and then spreads centrifugally to the limbs. And that's why you see a preponderance of dots on this schematic on the hands and feet. It can traditionally involve the palms and soles, but need not do so. It's not pathognomonic, but it's a reasonable place, of course, to look. And you can see that image on the central photograph on this slide. Now, I show you all this because this is the classical teaching, but I think our current experience turns a lot of this on its head. We're now up to over 2,000 cases globally in 42 countries, according to the WHO's estimates from about a week ago, and it keeps on changing. I should emphasize that here in Canada, our numbers are continuing to rise, albeit at a slower rate than some countries in Western Europe. And based on this, I think we're starting to really see some patterns in terms of how this emerges. And I'm going to show you some of the photos in just a moment. One of the key messages I'll put out is that the sequence of symptoms that I showed you in the last slide does not always seem to occur. In other words, patients need not present first with a febrile illness. Many patients are presenting first, or I should say developing first, cutaneous manifestations. And because those cutaneous manifestations may not be as dramatic as you're seeing on this particular slide, they may be just a handful or even a couple of lesions. Many people are at that stage not really thinking much of it, not really concerned about it, and may not therefore seek medical attention. So I'll show you some pictures in just a minute. Well, on the next slide. What's happening in many folks, because it seems to be spreading through sexual networks, so a sexual exposure, then sometimes the first lesions are at that site of primary contact, presumably at the site of inoculation. So here are some photographs of lesions at about day 7 or 8 in somebody who reported giving oral sex to a partner and then insertive sex, and hence you see lesions just above the lip. On the right-hand side, you can see lesions on the penis. There's a bit of a more punched out appearance to that particular lesion on the bottom. But then on the upper part of the right-hand image, you see this kind of ulcerative pustule that's starting to ulcerate. You can appreciate why the patients say that there's a central dark dot in the middle of their lesions. On the next slide, you'll see something similar. So a patient who reported oral sex had multiple lesions on the tongue. You can see that on the left. A patient who reported receptive anal sex had multiple lesions in the perianal area, and much of this extended inside the rectum as well. Patients can often present with really, really dramatic proctitis. In some cases, less dramatic proctitis, so just a little bit of kind of anal itching or pain. It has a spectrum of severity, but at the site of inoculation. On the next slide, I'm showing you some local lymphadenopathy. So this is some submandibular or cervical area lymph nodes in someone who presented with some oral perioral disease. And analogously, you'll see inguinal lymphadenopathy that's tender sometimes in patients with genital or perianal manifestations. And then on the next slide, you see that then you can have this kind of more disseminated rash in some patients. It's not as dramatic as that graph graphic I showed you a few slides ago. Many patients that we're seeing presently have just a few scattered lesions here and there. So you can see on the left some just faint macules. In the middle, you see a vesicle with some surrounding erythema. On the right, you see some pustules on the elbow. So the whole range of skin lesions are possible. Another thing that is quite different in the current outbreak that we're observing compared to what's described in textbooks is that you can see multiple stages of lesion development at the same time. Classically, it's described that they all kind of evolve together, but that's not what we're observing clinically this time. And again, it can be subtle, it can be all over the body. So do a careful derm exam. The next slide, I'm showing you a little bit of lesion evolution. So this is, the photographs are taken at a slightly different angle. So I put a blue arrow to show you the same location. You can see, and each of these photographs was taken 24 hours apart. So you can see how rapidly this evolved from this pretty faint little kind of bump on the left. You might not have even noticed it. And then on the middle and right-hand images, you can see it rapidly developing into a vesicular pustule and even starting to dry up and crust on the right. And you can see this triangle of 3 lesions, and you can appreciate, I think, that 2 of those are much less visible on the first image. So they do seem to evolve rapidly. They're often tender, they're often itchy. Thanks for the question. But not always, right? Of course, there's always this spectrum of clinical severity. In the next slide, you can see that in rare cases, it can be pretty dramatic. This is somebody who actually we hospitalized because of the extent of lesions. This person also had pharyngitis that was starting to, that had been impeding his ability to swallow and eat for a week. And together, these manifestations were felt to be severe enough to warrant hospitalization. He's doing better now with a course of antiviral therapy. But in rare cases, it can be more dramatic. And noteworthy that this particular individual, N of 1, does report and has a scar to corroborate him having been vaccinated against smallpox in the, as a child. This person is in his 6th decade of life. In the next slide, finally, I'm showing you some images of the involvement of the palms and soles. You can see, on the left-hand image, it's fairly subtle, but the patient noticed it. Like there's a whitish kind of bump, a little bit tender, and then more obvious in the middle and right-hand images. The image on the right was of the foot. This foot was completely normal to examination 24 hours before this photo was taken. So next slide. There's a differential diagnosis. Of course, this list here is not complete, but I'm just putting some things out there for you to consider if a patient presents with different types of manifestations. Genital ulcer disease, of course, would make one think of primary syphilis, HSV1 or 2, lymphogranuloma venereum. Chancroid is extraordinarily uncommon in our setting, so that would be, one to get excited about. In the middle, I put a list of things that can cause pharyngitis because I do want to note that although the classic manifestations I talked about were the febrile kind of illness, the cutaneous manifestations, and the lymphadenopathy, a limited number of patients are presenting with pharyngitis, about 20% in the Ontario data so far. So if you see that, it could be a false localizing sign. I mean, you want to see that probably with some of the other stuff, but there have been some patients where this is the sentinel symptoms. So just monitor those patients carefully, but think of some of these other considerations. And then on the right-hand side, this is very incomplete. The list of things that can cause, fever and rash is huge, but some common things to think about in this setting in particular, of course, varicella, perhaps shingles if it's more localized, enterovirus. We are seeing lots of hand, foot, mouth being picked up through people thinking about monkeypox. Disseminated gonococcus can cause a pustular rash, HIV as well, and consider co-infections regardless. If this is someone who reports a sexual history that would make you concerned about other STIs, test for them. Next slide. So this is an important point to touch on how to test for this. If you've got to the stage where you've got someone in front of you suspecting it, you want to test for it, you want to consider other diagnostic considerations as well, but the main maneuver is PCR. It's really the only maneuver that we have at this point. The highest yield is really the skin, but if patients are presenting in that really acute florid stage, you can sometimes get this picked up on other specimens, a blood specimen, an NP swab, just a plain throat swab, a urine specimen. Many of these are picking them up in that acute stage, but I would not say that the yield is high. I wouldn't hang my hat on just getting one specimen. Really, if the patient has skin lesions, that's where the money is. And ideally, if there's a vesicle or pustule, you'd unroof it and send some of the fluid inside, really rub that ulcer or that lesion as best you can in a tube with some viral transport media in them. Those are the vials such as that shown on the right-hand side. I just want to emphasize that here our lab colleagues have asked us to dump out most of the fluid and really dilute the specimen as little as possible. So this is something that literally requires you to pour out most of the viral transport media, because they typically have about 3 or 4 cc's in them. Unfortunately, serology is not yet available, although we hope it will be in the future. Now, on the next slide, there are some logistical considerations around seeing this. The IPAC considerations are appropriate, but with our experience with COVID, hopefully this is surmountable in many settings. The second issue is really an issue. So this has been was a category A pathogen. It's now been downgraded to a category B pathogen. Nevertheless, many specimen transportation services and groups are being much more vigilant perhaps than they would be under standard conditions even for category B pathogens. And many places are insisting that staff who perform the specimen packaging and transport have documented training in the transportation of dangerous goods. That's actually not that difficult to get, but because it's a step and it is not nothing, it has posed a barrier in many settings. If your site is not set up for this, and you might need to check with your local specimen transport teams, then there are other places that are rapidly kind of building capacity to accept referrals, but it is rapidly evolving, and it is we all acknowledge it is not where we want it to be yet. So certainly your local infectious diseases specialist would be a great place to start. Other places that are trying to build capacity are STI clinics. And so in Toronto, where the epidemic is really, really, really concentrated, all but like less than 5 cases so far in the province are in Toronto, the STI clinics are about to be online to be able to do this. And then other sites, this is evolving. Local public health units will be collecting and disseminating information about what sites are kind of online to do this. I should point out Ottawa Public Health is actually online to do this as well in some of their clinics. Next slide. The last thing I'll talk about is just vaccine really quickly. So there is a vaccine. It's in very, very short supply. It's called Imvamune. It's a 3rd generation replication deficient live virus vaccine against smallpox. We're one of the few countries that had this already licensed for use when monkeypox, this current outbreak began. And on the right-hand side, I won't read this out, but the Ontario CMOH office, in consultation with clinicians who've seen a lot of this so far, have identified the following as criteria. So transgender or cisgender individuals who self-identify as gay, bisexual, or men who have sex with men, and at least one of the following. And if you look at those other things, they're really things that are markers of some sexual activity. It doesn't need to be tons. You can just see like having one anonymous or casual sex hookup in the last little while is sufficient. And in the province of Quebec, they've opened this all up to just all GBM who are not in a closed monogamous relationship because they have a little bit more vaccine supply than we have right now. So it's really the vaccine supply issue that is limiting availability. It's also available, not listed on this slide, to close contacts of confirmed or probable cases. So that fans out once you've identified a case. Access to this is being rapidly scaled up in Toronto, where most of the activities happened. It's been organized by Toronto Public Health. There's some mass vaccine clinics. Look it up on the TPH website, or your local public health unit if you're outside of Toronto. Again, Ottawa has started to come online as well for this. In the next slide, I'm just reiterating the key messages. So suspect monkeypox when you see those combinations of manifestations. Diagnostic, as I mentioned, but I just wanted to flag those logistical considerations. Hopefully those will get more manageable soon. A vaccine is available. Recommend this actively to gay, bi, and other men who have sex with men in your practice if they're not aware, if they're sexually active with new partners, as well as close contacts of cases, and talk to your local PHU for more details. Last slide is just my own acknowledgements, my contact information, and my team's website. And the final slide is just a huge thank you to the community organizations. We've been really, really thankful for the mobilization and the collaboration with these and many other organizations, and it really is central to the response. Thanks so much.
Thank you so much, Darrell, for this really current and extremely clinically relevant practical talk that you just gave. People are really engaged. I have a few questions for you. So I just will say to folks, I know we're supposed to end at 9. We may end up going till 9:05. I just want to make sure that we have a chance to answer some questions. One question is from Kimberly. So actually, before I go to the questions, I do want to actually just flag that 4 weeks ago, when we had Dan Warshawski and Gerald Evans here, at that time, it was a Class A pathogen, and we were instructed to send people to the Emerge if they needed testing. But that's no longer the case, because now it is a Class B pathogen. It can be tested in a primary care office. It does not have to be in a negative pressure room. You take appropriate IPAC precautions, but at the same time, what Darrell has flagged is one of the barriers is this that there needs to be this training in the dangerous transportation of dangerous goods. So there are some clarification questions about that, Darrell. So just to clarify, if you can restate, if people are concerned about it, where should they be sending someone with suspected monkeypox?
Yeah, so thanks, Tara. It really depends on where you are located. But I think a safe bet is to say consult your local infectious disease specialist would be a very reasonable thing to do. Do not send a well person in whom you're just suspecting this to an emergency department. That's going to clog the Emerge. And other settings that you can send them to, as I alluded to, it's evolving, and it's evolving so rapidly that I hesitate to say that there's a definitive, clear answer that'll apply across the province. As I mentioned, in the city of Toronto and probably in the GTA, it's probably reasonable for people to try to go to the local Toronto Public Health sexual health clinics. There's a couple of them that are online that right now that have reopened after COVID. One of them is at Crossways at Dundas West. The other one is, I can't remember which other one is open. In Ottawa, what is it called? Centertown, I believe, right in the market is available to do this, and other places are coming online. I hope that answers the question.
Yeah, and I guess we should be continuing to get communications from our local public health unit about where to test. And so do please reach out to your local leaders around that. So I'm just going to go through a few questions, and maybe I'll just ask if other people on the call just don't touch the Q&A because it's going up and down. So Kimberly Wintemute asks, for the mouth and perianal picks, I would have swabbed those for HSV. Will monkeypox automatically be tested if we indicate MSM on an HSV swab?
It's a great question, and the short answer is no. Send them specifically. In the future, it would be great for us to try to go back to specimens like this retrospectively and see to what extent we might have missed the diagnosis in cases, but no, send them separately. One other practical point here that I will make for clinicians is that, you know, if you send for this and HSV and monkeypox, or monkeypox and anything else, and you mark it as, you should mark it as such, say that the differential includes monkeypox, or it'll be implicit because you're sending it for both. And the lab will delay testing on the other organism until they've done the monkeypox testing first. This is a biosafety issue for the lab technologists. That's important for their wellness. So therefore, there's going to be a diagnostic delay. There's already a 48 to 72 hour turnaround just to get this critical PCR on the monkeypox. I wish it were faster, but that's where it is right now. It's 24 hours in Quebec or so, according to our Montreal colleagues. But that's just to get the monkeypox result. If that's negative, then they will go on to do the other testing. So there's a significant delay, and therefore the clinical implication is empiric management of other things is very reasonable. So go ahead, give the acyclovir, valacyclovir, famciclovir, go ahead and give the benzathine penicillin if you're worried about syphilis, etc.
Thank you, Darrell. So Adrian Chen has very helpfully posted a link to the Toronto Sexual Health Clinics that you could access. And Irene Armstrong from Toronto Public Health is just emphasizing with the change to Category B, it's recommended that testing take place in the clinical office practice. So there are some questions just about smallpox vaccination. So I thought smallpox vaccine provided some protection, says Andrea Stern. I heard 85%. Would that not provide some protection against severe disease? You know, that people are asking about this patient whose picture you presented. So Irene Chen asked a similar question, which actually, sorry, Diane Hathorn asked a similar question. Does smallpox vaccine as a child provide the long-term protection against monkeypox?
Thanks. Let me answer that. Excuse me, but also just to highlight Irene Armstrong's comment. Absolutely, if you can do it in your office, do it. And I was just highlighting that there are these logistical barriers that many primary care sites are reporting. So just look into that, you know, so that you know whether you will be able to successfully transport the specimens. We've had some clinicians do everything right, collect the specimen, send it off, but then they get, you know, blocked at the transportation stage. So to move to the smallpox thing, absolutely. These are very closely related viruses, and hence it's thought that smallpox vaccination as part of the global eradication effort in the 1970s and early 80s and before, ended prior to 1980 in Canada, would be protective. So yes, it's thought that there's some protection. In fact, it's also thought that the waning, the cessation of that global vaccine campaign in the early 80s globally is part of what may have contributed to the rapid emergence of the re-emergence of this pathogen globally now in younger people. Most people affected in the current outbreak globally are in the 30s, 40s. So that's younger than would have received this. But what we do not know is the extent to which that vaccination from the 1970s is still durable today in 2022. Of course, it's 4+ decades that have elapsed. So it's not surprising, I think, that there's going to be some infection that occurs in folks. Yes, we think it probably attenuates the disease. That would make sense, but we don't have data on the extent to which that's true.
Thanks, Darrell. So Irene Chen builds on that by saying, if an MSM patient is interested in Imivane for monkeypox and also got the smallpox vaccine previously, would they still be eligible for the or recommended to get Imivane?
Yes, go ahead. So Imvamune, right? Imivane, something very different. Imvamune.
Imvamune. Yes,
yes,
I think sorry about that.
I'll point out there's a NACI statement on this. I should have pointed that out specifically. Maybe someone can dig it up and put it into the chat, but you can just Google NACI statement on monkeypox. It came out just, I've lost track of time, a week or two ago, and it's got really detailed information in there.
Okay, and then Jenny Clement and some others have also asked this. Jenny Clement says, in Ontario, have there been any cases of non-LGBTQ2S QS2 population getting monkeypox? And I think someone else, I think it might have been Kimberly went to mute, says, have there been any cases in kids? And I think this goes to the broader point of there are many people who are worried about it that probably shouldn't be, and how do we reassure them?
Yes. So, okay, again, globally, 99%, okay, are self-identifying as GBM. In Ontario, there's a data lag, as usual, but the most recent update of confirmed cases, 100% male, I believe of them all men of sex with men. But there's a lag, so it keeps on changing. And of course, close contacts are the people who at this point, I think it's fair to say we're confident that the way that this has come about is through sexual networks. Okay, so that's what we're observing. Is there a risk of other people acquiring this? Of course. Is that a huge risk? No, it is not. You would really want to see a link to someone who is a confirmed or suspected case, or someone else who would have reason to have this infection. To really heighten your level of suspicion. I should highlight that if that is relevant for pediatrics, for people who can become pregnant or are pregnant, that is a setting where you might want to heighten your level of suspicion, because we do believe that the risk of clinical severity might be higher in those individuals. So if you have someone in that situation, then yeah, reach out for some consultative advice.
It sounds like there are a lot of people who we probably could reassure just based on the epidemiology, is what you're saying, Darrell.
Absolutely. Thanks for saying it that way, Tara.
Okay, so and then Jenny Clement, I think Jenny Clement just wanted to clarify, what's meant by the transport, this being training for transportation of dangerous goods. Do you mean like the people, or is it the transport company? Can you just expand on that? And then I think.
Yeah, so the process of like, if you have a dangerous pathogen, many things are category B actually that we see routinely. There's just some strict regulations that set out how one is supposed to just package it, double package it, label it appropriately, and then for transportation between locations, there should be it should technically be placed in a special box that's marked in a special way. And I think, to be fair, historically, what's happened is that many people are not necessarily just rigid about enforcing those very, very specific requirements. But because of what's going on, people are just kind of paying attention to those rules a little bit more. So technically what it means is that the person who literally packages it into whatever receptacle is going to go to the lab should have this certification technically. And then whoever's going to transport it, okay, whether it's your local lab, your Life Labs person, or whatever it is, should have this certification as well. And so there's kind of just more checking of this. So you need to just speak in your clinical setting to whoever organizes your specimen pickup, what the deal is. Okay, and then the TGG training is, like I say, it's actually not that complicated. It's like this. It's like slightly painful online module that you can do, and you get the certification and you follow it, and that's it. And you do need to have like the relevant packaging to label things and etc. So it's not that it's surmountable, but it is a step. And so just speak to whoever is responsible for this in your setting.
Thank you, Darrell. And thank you to Adrian Chen, who continues to put some great stuff in the chat. Just so for folks to know that we'll put all the links together as usual in our resource list and email it out to you. Even though with the time, I'm going to still ask maybe a couple more questions because there's so many good ones. So somebody else has also asked, is there any correlation with people being HIV positive? And Allison Liu specifically asked, can HIV patients who are positive with the CD4 count under 100 get the vaccination?
Great questions. So yes, not surprisingly, there is considerable overlap with people living with HIV because this is spreading through a sexual network that already has a high prevalence of HIV. So yes, that's happening. The safety of this particular vaccine, Immune, has been studied from a safety perspective in people living with HIV. And in the trial, there were no safety signals. The caveat is that the people in those trials who were living with HIV had CD4 counts of greater or equal to 100. Okay, so technically there's a bit of a data gap in terms of people with lower CD4 counts. So by the medical directives that some of the mass vaccination clinics are operating under, that's the requirement that if you're living with HIV, your CD4 count should be greater than 100. If you're less than that, it just doesn't fall under the medical directive. The person can probably still get the vaccine, but they just would need to be counseled appropriately. So there's a directive. So because that person would fall outside the directive, then the advice would be that this be discussed with them specifically. I think most of our clinical judgment is we would feel comfortable giving it, but it would be outside the what's been recommended for the frontline nurses to do under a medical directive that's designed to allow for rapid administration of the vaccine to many people.
So Lauren asked, how high is the confidence that monkeypox is not contagious until symptom onset? If this is the case, it will be helpful to control transmission compared to viruses with contagiousness in the pre-symptomatic phase.
Yeah, that's a great question. Yeah, I mean, I think we're fairly confident that it doesn't transmit during the incubation period. The caveat to that is, okay, as I said, a good proportion of people who are being diagnosed with this infection during this current outbreak are, yes, they're presenting, they're having symptoms that you would think might bring them to medical attention, but they don't always present to medical attention because the severity of those symptoms in many cases is modest. I showed you photographs of people who had just a single thing over their lip, right? Or a single lesion in the genitals. That's not going to prevent someone from living their life, right? They develop something they think is maybe a zit or a pimple initially. They may go on, quite rightfully so, living their life. They may have sex, they may kiss people, whatever. And so I think that's where the concern about potential for transmission continues, and just means that we have to have a heightened level of awareness in the community and as clinicians.
I wonder if you could also just comment on monkeypox treatment, Darrell, which I don't think you touched on.
Yeah, sorry, I didn't touch on it very much because, frankly, we're extremely limited by supply. Okay, I should point out the part of the reason that the supply is such an issue is that smallpox historically and monkeypox by extension have been considered bioterrorism threats. Therefore, the stockpile that exists in Canada of therapeutics and preventative tools, antiviral treatment and vaccines, is literally a security secret. Okay, and so the feds cannot divulge how much of this is stockpiled and how much they're giving out, what proportion of the total supply that represents. It's a state security secret, okay? And that's likely not gonna change anytime too soon, I would think. Therefore, the supply that we have of treatment specifically is extraordinarily limited, much more so than even the vaccine. And as such, it is basically not that available for people who just are basically okay with this nuisance kind of set of manifestations. If someone has severe manifestations, that's when we would think about it. It's probably basically going to be folks in whom you're considering sending them to the Emerge because of severity of their clinical presentation, and in extenuating other circumstances where you really think it might be worth considering for some reason in an ambulatory patient, consult your local PHU.
Thanks, Darrell. So just another, Adrian Chen is saying that they met with public health and the ministry yesterday to flag these issues with Life Labs and Dynacare, as both organizations have actually agreed to transport category B. There's some hiccups. So if you as clinicians run into problems with those two organizations refusing to transport, she's actually put her email address there. So I guess the last question I'm going to say is just about the vaccine, Darrell, and that's just the, I think you kind of spoke to this, what's the plan for the ongoing release of the supply? So you're saying we don't know because it's a state security secret. And then anything you want to say about the safety and efficacy of the vaccine, how long it takes to work and how long it's effective for?
I mean, wish we knew is probably the best answer. We don't have true human clinical trial data of this vaccine specifically for monkeypox infection. The data are immunogenicity data, safety data in humans, and then there's some kind of extrapolation from kind of protection against manifestations of vaccinia, smallpox vaccine-induced manifestations of disease. So it's a lot of extrapolation. So bottom line, we don't know, but we have good reason to think it's going to have some benefit. How quickly, again, don't know. Immunogenicity data suggests you have good responses by about 14 days. Yeah, I should also point out it's by the books, it's recommended as a 2-dose vaccine, 28 days apart, but because of limited supply, just as we did during COVID-19 at the beginning, the effort, the priority is right now just get first doses into arms right now. We'll worry about the second dose stuff later.
Thank you so much, Darrell. So I know there's still a few outstanding questions, but I think we're well over time now. I'm going to ask Olivia for you to just bring up our last slide. So thank you, Darrell, and thank you, Allison, for a terrific hour. You can see from the comments just how appreciative people are for you taking the time and how this session has provided them with really practical information. So a reminder to everybody on the call that the full recording will be posted likely later today. I know some of you were like, but what did he say? Exactly. Did he say this? Did I hear this right? Well, you can go to the recording and fast forward to the relevant section. We will be also putting forward all of the resources, and we'll reach out to a few folks just to try and make sure those are as thorough as possible. And then our next community practice will be on July 8th. We will, after that time, take a bit of a summer break. But stay tuned for the one on July 8th, where we'll have Dr. Fahad Rasak, who's the new head of the Ontario Science Table, join us. And if you have any suggestions for other speakers, we always welcome them in the evaluations that you'll get. So thanks again to the speakers, Darrell Tan and Allison McGeer. Thank you, David Kaplan, for being my co-host today and for all the questions you've answered and the leadership you've taken. And thanks to all of our team at OCFP and DFCM who make these possible. And finally, thanks to all of you who tune in and are absorbing and engaging in all of this information to do your best to provide the best patient care possible. Appreciate that, and hope you guys have an enjoyable weekend. Take care.